Uh, So as you can see, our participants have started to join. So let's start the session now. Good afternoon, all. My name is Agatha Susan, Program Officer at India Vision Institute, Chennai. I would like to welcome you to the inaugural session of Decoding Myopia Insights on Myopia Management and Control, presented by IVI, supported by Hoya. We would like to take this time to appreciate Hoya for bringing us on this topic and actually sponsoring this and giving us a chance to have this on the platform. I would like to take this opportunity to introduce our speaker for this module, Dr. Chandrashekhar Chawan. Currently, Dr. Chawan operates the Shekhar Eye Research in Thane and also practices in Los Angeles, USA. In 2004, he introduced clearer lens technology to India after acquiring it from Boston Foundation for Sight. Additionally, his proficiency extends to painting on soft contact lenses and RGP scleral contact lenses. Recently, Dr. Chauhan invented photochromatic scleral lenses for patients suffering from glare and light sensitivity. Thank you very much for taking the time for this session, sir. Welcome, sir, and over to you.
Thank you so much. Uh, it's a really a great honor to be a opening batsman for your wonderful educational program.
Thank you, sir.
And I guess you will be doing the admit and everything, right? I Yeah,
Yes,
because
sir.
I think I'm also one of the host. Okay, let me share my presentation. Uh, do you see my screen?
Yes, sir.
Wonderful. Okay, so I have a lot of things to talk, so I will not waste much of a time in pleasantries. Since this is a talk about myopia control, and I saw there are so many other distinguished speakers lined up in your series, so I guess I get a chance to introduce what is myopia control. So I have no financial interest in the talk. So, talking about myopia management, first of all, we have to know why the myopia is everybody is talking about, and it has become so important. So, after COVID, we have realized that most like there is a lot of awareness about it. Even before that, there was awareness. There was a lot of paper published. One of the major publication from Brian Holden Vision Institute talked about 50% of the world's population is going to be myopic by 2050, and everybody started working on similar things. Mostly the prevalence of myopia is more in Asian countries, China, Singapore, Korea. So those are the countries which were actively doing something, doing a lot of research, and in India we used to think that it's hardly maybe 9% to 25%. Different papers talk about it at a different level, but after COVID everybody realized that it is there, it is happening in India also. So is it really serious? Yeah, we have been prescribing glasses, myopia, hypermetropia, and what's a big deal about it? So the big deal is because of the axial length elongation. We are talking about axial myopia, not a curvature myopia or media due to media. It's axial myopia. So what happens is the eyeball gets stretched, and because of that stretching, as most of you know, that 1 millimeter of axial length elongation is almost equal to -3 diopters. So the risk of increased axial length is glaucoma, maculopathy, retinal detachment, early cataract. I consider this is so serious as I equate it to hypertension is equal to cardiovascular disease. Everybody knows that if you have a high BP, you are more likely to have more chance of heart attacks. If you are smoking, you can be more susceptible to strokes. So similarly, myopia also is risky for loss of vision. But there is a good news. Even if you try to control myopia progression by even just 50%, you can control the risk of glaucoma, cataract, retina detachment from 60 to 90%. So that is the need, and we being the forefront of the first contact with general population for eye care, we should be aware of this. Now here I want to say that we are equally, partner in crime for myopia progression, because we are the one who give single vision glasses. We, I mean, all eye care practitioners, optometrists, ophthalmologists. So why I'm saying this? Because the moment you give a single vision glass, it is just a corrective glass. Okay, but it doesn't prevent myopia progression. In fact, it stimulates myopia progression by causing a hyperopic defocus. From this lecture, you have to understand at least these two terms today: hyperopic defocus and myopic defocus. Hyperopic defocus will stimulate brain to keep on elongating the eyeball in axial length, and myopic defocus will try to control the axial length elongation. So when you give a corrective glass, the uh, the image shell, of course it is focused on the macula, but the peripheral image shell crosses the eyeball and it forms a hyperopic defocus that sends signal to brain to increase in that direction, and that is how the vicious circle follows. So what is the solution? To create a myopic defocus. If you create a myopic defocus, you need a clear vision for distance as well. So you need, instead of one focus, you need two focuses. So that is where all these optical devices are in the market now. And most importantly, orthokeratology works fantastic because it has a natural, the design itself gives you two focuses. I have been doing orthokeratology since last 20 years, but last 15 years I realized that it can work for myopia control. Before that, it was just alternative to wearing spectacles or alternative to LASIK. But then over a period of time, we realized that reverse zone in that orthokeratology lens gives that myopic defocus, and that is the one which is controlling axial length elongation and myopia control. One of the famous optometrists in the US, Earl Smith, who is a research scientist at Houston, he has published a lot of papers, done a lot of work on animals, and he has proven the defocus theory. He could create a hyperopic defocus and let that particular region of the eyeball elongate or control. So this has proven, even after cutting the optical nerve, the eyeball size shape changed. So that stimulates lot of other research. And this particular monkey trial, they divided these two groups, and one group of monkeys, one eye they gave +5 diopters, in other eye they gave -5 diopters, and one eye was normal to compare what happens. So surprisingly, when they have given +5 diopters, all those eyeball did not grow compared to the normal eye, whereas -5 diopter eyes increase in axial length compared to normal eye. So this again proves the optical stimulus plays a major role. Obviously, eye is an optical device for the, it's a part of brain. There are so many other, like 120 genes responsible for myopia. There are so many other reasons, but optical stimulus is the major reason for the axial length elongation. So what can you do? You need two focuses. So you can have bifocal glasses, progressive bifocal. You can have a contact lenses with a center distance, periphery near. Even a near distance and periphery reverse also works in some cases, but for myopia control you need a center distance and periphery near optics. And orthokeratology, of course, it works on the same principles. It is not only the optical stimulus that will help, but you have to have a kind of a holistic approach. The environmental factors are to be considered: near work time, near work distance, amount of illumination, the time spent outdoors. There are so many factors, so it has to be combined with rest of the things to have a effective myopia control. Most of the myopia stimulus happens because of the close work. when you see any objects at close distance, the natural eye is designed to see at a distance. So when the rays of light coming from distance, they usually do not cause hyperopic defocus. But the moment you bring any objects closer, your optical lens, the crystalline lens, will focus the image on the retina, but the peripheral image shell goes out of the boundaries of the eye. That is, we are calling a hyperopic defocus, and that sends signal to brain. So if you spend more and more time doing close work, reading, writing, or mobile phones or tablets or anything, more time you spend for near work is directly going to cause the stimulus to the brain to increase in axial length. Now, for whom it is important? Of course, for children, because children are the one where the eyeball is now growing and it is forming a shape, and that is the time we can have to whatever intervention you want to do and create a myopia control. So basic thing what you need is two focuses, one for near, one for distance. And distance, the peripheral optical stimulus, if you can bring it to plus power, then it will bring that myopic, the hyperopic defocus to myopic defocus, and this is what we are interested in. So how you can control myopia? By bifocal glasses, progressive glasses, 360-degree addition lenses. There are DIMS technology, lenslet technology, mobile spec, defocus lenses, variety of it. Now fortunately in India we do have access to all these technologies. uh, all this, the SLR has a Myopilex where they have a circular plus dots, the ring, concentric rings. This is a Myo Smart lens which has a honeycomb pattern. They call it a DIMS technology. So all these lenses have a prescription for distance, and this stimulus for optical causing the myopic defocus. And now everybody has their patented designs and powers, etc. But all the lenses which are available in the market today for specialized myopia control spectacles do work anything between 60% to 70%. If you do a research, if you read research paper, there are a lot of papers available online, and it does prove that it works. So similarly, this is one of my designs. I call it Myokido. So this is only to be used while you are on a computer or mobile or doing any close work. So principle is same for everything. It is causing a myopic defocus. So this is one of the soft contact lenses, which is the only FDA approved contact lens as of now, called MySight. It has a concentric ring, so distance and plus power, distance and plus power, like that, and it does have a wonderful effect on myopia control. It is still not available in India, but hopefully it will be launched in India soon. So another thing, you can control myopia by pharmaceutical agents of atropine. So they tried starting from 1% atropine, 0.5%, 0.05%, 0.025, 0.01, and in India now it is commercially available 0.01%. There are a lot of papers that came up using all different concentrations, and it depending on the risk of myopia, one can select what kind of dose you want to give for effective myopia control. Now only problem with atropine is you have to stop after 2 years and then again give a gap of 6 months and then again you can start. So what they have found is there is a lot of rebound effect. When you stop after 2 years, whatever myopia you controlled again bounces back. So you need a optical stimulus also, and optical stimulus in my opinion is most important. And if you combine with this pharmaceutical stimulus, you will have a very nice and effective myopia control. So I, along with Dr. Maskati and Dr. Jethani, created this risk factor because yes, now it is the child is myopic, but not every child is going to be as risky, because there are a lot of history, lot of genetics. If one parent is myopic, both parents are myopic, ethnicity, at what age, the earlier the onset of myopia, the more likely the myopia will increase as the child grows. So all these factors we considered, and we have given some numbers to it, and then you add all this, and then if it is less than 6 points, then you are okay, the child is just you keep on monitoring. If it is between 7 to 12 points, then you have to start actively giving some kind of spectacles or contact lenses or orthokeratology, or if even just start with atropine or something like that. But if it is more than 12, then you have to go aggressively. You have to combine atropine, optical stimulus, whatever things you have, you have to give that to that child and control the axial length elongation. Okay, so I got stuck. So start early, consider parental myopia, time outdoor, close work time, lighting condition, food, etc., etc., and measure the axial length. Okay, that is what we are trying to control, not the power. You are trying to control the axial length. Power is just that you can easily find out. And if it is more than -5, you start a dual therapy. It's up to you. As I said, you go follow my risk calculator and incorporate dual therapy, that is optical stimulus plus pharmaceutical stimulus. So basically, for regular orthokeratology, for myopia management for adults, we try to keep the maximum amount of target zone, or visual optical zone. Whereas for myopia control, you want to keep this optical zone smaller than the pupillary diameter. Then only it is going to cause a myopic defocus, and it will be more effective. So I looked at some papers online, since my topic is rigid gas permeable lenses versus orthokeratology. So rigid gas permeable lenses are equivalent to spectacles. As they do not cause any myopic defocus, they just give a corrective phenomena. So RGP lenses are not as effective in controlling myopia. So whereas if you use orthokeratology lenses, it is more effective because, as I said, it has a dual focus. One focus which gives a distance vision, and a peripheral, that reverse curve, gives you myopic defocus, and it controls axial length elongation in children's. So this is more effective, and when you combine that with atropine, you get a much better results. I'm going to show you one slide, one of the papers. I call it a plus power dose, or that red ring what you see in the topography maps is the indication of how much strong signal you are giving for myopia control. And when you combine with atropine, you get a much better control. So this is what the paper I was talking about. This has compared 1 year of axial length elongation. Control eye elongated just 0.4 millimeters, whereas the group where 0.1% atropine was used, it got controlled by 0.36. 0.25, 0.25, more the strength, more the control. So 0.05 was more effective, 0.02. But it is found that 0.05 do get little bit of dilatation of the pupil. Accommodation is not affected, but the pupil gets slightly dilated. Now another comparison between normal eyes and orthokeratology. So orthokeratology was more effective, or is equivalent to 0.05% atropine. But when you give a dual therapy, atropine as well as orthokeratology, it was 0.09%. So it is more effective when you combine both. Now let us compare the GP RGP lenses and orthokeratology lenses. So RGP lenses are required to use during the day to see clearly, just like a spectacles. They correct vision by the shape of the tear formed behind that, so it neutralizes the irregularity on the cornea, and you get a sharp and clear vision. Whereas orthokeratology works by wearing the lenses overnight. It temporarily reshapes the epithelium of the cornea, giving a clear vision throughout the day. We call it a holding time. So you get about 16 hours of holding time, uh, so that the child can see clearly without any distortion. Of course, there is a overcorrection in the morning, afternoon you have full correction, by evening it is little less correction. but the child doesn't understand the difference and he enjoys a clear vision. So it does offer some kind of a myopia control if you go with the my first slides about the hyperopic defocus, but actually the paper talks that there is nothing great about RGP lenses, whereas orthokeratology lenses do work. There are a lot of papers who says there is a 68 to 84% of myopia control with the use of OrthoK lenses. Uh, the lenses, RGP lenses, of course, whenever you want to see clearly, that means 10 to 14 hours, you have to wear RGP lenses. Whereas OrthoK you wear when you are sleeping 6 to 8 hours, and you can enjoy a clear vision throughout the day. No need to wear the lenses during the day. So may require adaptation period. It gives discomfort because of the lid awareness. The lens keeps on moving. So you can go larger and larger diameter lenses, even 90% of the HVID you can select and reduce that awareness and pain. Whereas orthokeratology, the diameter is almost 92% of the HVID, and you are wearing it during sleeping hours, so it doesn't cause any irritation or pain or anything. And during the day, you are just removing the lenses. So RGP lenses do provide sharp and stable vision throughout the day. In OrthoK, it does vary, as I said, but it gives maximum myopia control because of the reverse zone. So diameter, as I talked about, it is available from 8.8 to 10.2, depending on how you are trained to fit RGP lenses. I'm going to show you some slides on basics of RGP lens fitting after this. Orthokeratology, usually 92% of the HVID is required to get a central and stable lens. There are different kind of materials available for RGP lenses. Basically, OrthoK lens also is a RGP lens, but it's a reverse geometry lens. But you need minimum 84 dk to 160 to 200 dk because you are wearing the lenses during the closed eyelid condition, sleeping hours. Whereas RGP lenses, even if you have 30 dk or 100 dk, 120 dk, doesn't matter because you are wearing it during the day, and there is a good amount of tear exchange because of the blinking. The life is about same, but you may need to replace the orthoK lenses quite often because the protein buildup in that reverse zone. RGP lenses you can wear as long as you want, but there is a chance of warpage also depending on the material used and how you are handling the lenses. So, impact on daily activities, RGP lenses are sometimes inconvenient for sports and dusty environment, and lenses can pop out of the eyes. There is always the awareness of the lens in the eye, whereas ortho lenses you are not wearing during the waking hours, so you're absolutely comfortable, confident. You can be just like a normal person, and there is no effect of any dusty or windy environment. Now, eye health and risk, if you compare, both needs good hygiene and proper care. But for orthokeratology, I insist on doing a hydrogen peroxide disinfectant system because you are wearing these lenses in the night time. During the daytime, if there is an infection, you will see that there is a redness, there is watering, there is photophobia. Whereas orthokeratology lenses are worn during the night, so you don't know what's happening under that closed lid. Only in the morning you will know if there is an infection. So you have to make sure the lens goes in the eye fully disinfected. Cost is expensive. OrthoK is more expensive. RGP are less expensive. Uh, so both lenses required, as I said, the maintenance and hygiene. But in orthokeratology lenses, no tap water. Don't use any tap water for cleaning RGP lenses because for the same reason, if there are a lot of bacteria and dust and other thing in the normal water, and that can go in the eye. Especially there is a high risk of acanthamoeba infections, which is more dangerous. So no tap water to be used with orthoK lenses. Uh, for selection of patient, actually RGP lenses you can correct up to whatever minus 30 diopters also. Of course, we are talking about low myopia, but still there is no limit for myopia correction in RGP lenses. For orthokeratology lenses, it is FDA approval is up to only minus 5 diopters, but in reality there are some labs which will make any lens up to -12 diopters. And now there are toric lenses, because we have found that a lot of children have astigmatism along with the spherical power. So those patients who have limbal to limbal astigmatism, they do need a toric lenses, and you can correct up to -3.5 diopters of toricity. So in conclusion, both RGP as well as OrthoK lens offers a unique advantage, but if you want specifically for myopia control, then orthokeratology lenses are your choice. So there is one more tip I would like to give is, suppose if you are giving a regular RGP lens and you still want that myopia control to happen, you can always use those specialized glasses which I showed you before on the top of the RGP lenses, or even on orthokeratology lenses, because that will cause a more stronger plus power dose, or cause a myopic defocus and send signal to brain not to grow. So this is just a crazy tip. You can still have plano lenses, and then you don't have to change every year. Whereas if you give a prescription lenses, these are very expensive lenses, spectacle lenses. So you have to change if the power changes. So if you spend some money on the RGP lenses and then use these plano lenses on the top, I think you get the same effect or even more effect. So in conclusion, both are the good options, but the life style change and the confidence and everything, more effectiveness is because of the orthoK lenses. Now let us go quickly into the for the newcomers, those who have not fitted RGP lenses or don't know much about it. So these are basically, you have to decide the material, design, indication, contraindication, and assessment you have to do. So material is you identify depending on the oxygen permeability. So dk by t, dk is the oxygen, the diffusion of coefficient of oxygen, t is the thickness of the lens. If more, the more thickness, less and less oxygen is going to be available at the back. Wettability is important, rigidity, modulus of elasticity. So the oxygen is most important. Previously we used to have PMMA lenses. Wettability is, if it is not good, then patient may not see clearly. Lens has to be rigid to maintain the shape, uh, because that way it will hold the tear layer behind. Modulus of elasticity. Lens design has a different designs depending on the irregularity of the cornea. If there is a keratoconus, you have multiple curvatures. For a regular myopia, you have just 3 or 4 curves. Indication for RGP lenses, right from myopia, irregular astigmatism to keratoconus. These are the different materials available depending on the oxygen permeability. The indications are astigmatism, irregular cornea, post LASIK, post PKP, orthoK, ocular surface disorders. It's very difficult in ocular surface disorders. You have to go for a large diameter lenses called scleral lenses. For keratoconus, of course, corneal RGP lenses works, PMCD and RK. So extreme dry and dusty environment are not good for corneal GP lenses, because they move up and down, and that the foreign body particles can get trapped in between the lens and the cornea and cause a lot of irritation. Advantages, of course, good quality of vision, low maintenance cost, and the life is longer. You have to handle with care, and doesn't cause much of a new vascularizations or any other issues on the cornea. Of course, you need a adaptation time. Initially they are very painful because of the lead awareness, but over a period of time patient do get used to it if it is there is not much of a movement. So that's why I said you go for a larger and larger diameter of the RGP lenses. So you have to do regular refraction, slit lamp examination. Sherman test is also important to understand how much is the tear production. I'm just giving this as a general guidelines, okay, not only for children but adult also you can follow these guidelines. Diameter depends on the HVID or VVID, lead characteristics. Pupil size will decide your optic zone. Start with the K, use the fitting sets, and do a dynamic fitting checks, let the lens sit on the eye for some time, and then you see whether lens is decentering, whether it is stable, what happens after blink, is it moving faster, slower, high riding lens, low riding lens. Once you start actually practicing, you will know all these things, and how much amount of movement is there, what type of movement is there, speed in directions. I don't know if this video works. uh, no, I guess. So basically, if you have a steeper lens, you have created a plus power behind the lens because of the tears, and you have to correct accordingly. Most of the time, your spectacle power will match with your contact lens power if there is no much of a irregular shape of the lens, and that way you can change the base curve of the lenses, and the diameter of the lenses will give you the stability. Base curve of the lens will give you the correct power for correction. And if you order the lenses, your lab needs to know the base curve, power, diameter, and optic zone, and material that you want to use. There are markings for right and left eye. Sometimes nowadays, instead of marking, we use blue or green or red or blue, yellow and red lenses for right and left eye. The pricking sensation, as I said, is a major discomfort to start with, but if the patient uses for a few days, he gets used to it. Care and maintenance is important, even if it is RGP lens or OrthoK lens. So hydrogen peroxide is what I routinely advise to all my patients, and no tap water. Orthokeratology lenses are basically lenses to be used under the closed eyelid condition. You cannot use this during the day. You can see with the lenses during the day, but it is advisable and FDA approved for nighttime wear. So what happens basically is the different curvatures of that lenses cause central push and peripheral pull. This 50 microns of thickness of epithelium, is reshaped overnight. So these are the curvatures: base curve, fitting curve, alignment curve, peripheral curves. So base curve is the one which is going to give you the vision. The peripheral curve, reverse curve we call it, because of there is a space, the epithelium tries and swells it there and fills it and forms a negative lens. And third curve is the alignment curve that maintains the balance, the centration of the lens. And edge is basically allows the tear exchange to happen. You need regular instruments that you have as an optometrist, but additionally you need a topographer, because you are changing the shape of the cornea. So the topographer is going to tell you what changes you did. If you use just a keratometry, you are getting only 2 data points, where a topographer will give you 1000, 10,000 data points. And which is more important, there are a variety of topographers available in the market. Image capture is most important before you start doing any alteration on the corneal epithelium, and fluorescent evaluation will give you a rough idea what is happening on the. So what you are going to see with ortho lenses is a central touch, whereas in regular RGP lenses, this is what you see. Here you will see a central touch, and there is a pulling and then again a touch. When you see a subtractive map, you will see what effect you caused. So this is the basic map, and then after the treatment of orthokeratology lenses, this is before and after, you subtract it, and this is what you get. This is called a bullseye map. And this treatment zone, you have to get it in between the pupillary zone. So for myopia control, you have to get this kind of a subtractive map. You have to use tangential map for subtraction, and you will get this red ring. And more the stronger red ring, you are going to get a more and more plus power dose, and you are giving a very strong impulse to the brain to control the myopia. And make sure that it is in between, in lies in the pupillary zone less than 5.5 millimeter. So this is what you are interested in, bullseye. If you are getting a smiley eye pattern on a topography, then the lens was riding high when the child was sleeping. If there is a central island, lens was not sitting properly. If you have a limbal to limbal astigmatism, then you need a toric lens. If the astigmatism is only in the center, you can manage with the spherical lenses. So this is, we call it apical astigmatism and a limbal to limbal astigmatism. This can be managed with a spherical lens. and limbal to limbal astigmatism, you need a toric lenses. So there are different forms of maps that you need to study: axial map, tangential map, elevation map, refractive, wavefront, height. So all this will give you a different information from the same cornea. As I said, if you have a limbal to limbal astigmatism, you have to directly go for a toric lenses. This is how the toric lens fluorescein pattern looks like, and this is a symmetric lens. So use different maps. If the lens is riding low when the child was sleeping, then you will get a frowny map. So do changes accordingly. You can discuss this with the lab. In fact, fitting a OrthoK lens is much easier than a regular RGP lenses, because here you just need to give HVID, refraction, and the uh, K1, K2 of the eye, and the lab will make the lenses for you. And if there is any difference of, say, central island or frowny map, smiley map, you just send that map to the lab and they will do the appropriate correction in your lenses, and they will send you a second lens. In my experience, all the labs are very sophisticated. All the lenses are made in US, of course. So their success rate is almost 85 to 90% first fit success. Very few lenses needs to be altered or changed. That depends on how complicated cornea you have selected. But 80% 90% success rate is very good enough. You can confidently start incorporating orthokeratology in your practice for myopia control. So smaller treatment zone is used for myopia control, and larger treatment zone is used for a regular myopia correction for adults. So as I said, you just need to send refraction, K1, K2, HUID in topography, and the lab can make it. Make sure that you use hydrogen peroxide as a disinfection system and a very clean hygiene, so that no infection happens, and you are safe, and the treatment is also safe. We don't want to cause any microbial keratitis or acanthamoeba infections or anything else. So there are a lot of other alternatives available in Indian market. This is very expensive, but there is a easy sept by Bausch and Lomb available in Indian market that can be used. Don't use a hydrogen peroxide from chemist shop. It has a preservatives, and that can cause irritation. So follow up is just next day follow up is important. 1 week, 1 month, 6 months. So one day, next day, and 1 week follow up, you can pick up if there is any frowny map or smiley map, and then you can immediately stop the treatment and send a lab that information, and lab will send you another lens. And if everything is okay, if there is a bullseye pattern, then you just monitor after 1 month and every 6 months. So every follow-up you have to check vision or refraction and topography. These are the famous contact lens manufacturers from US: Euclid, Contex, OK, Paragon CRT, Wave. In India, we do have access to Paragon CRT and Contex. Paragon CRT has a fixed 100 lens fitting set from which you can dispense the lenses. They do not have a typical myopia control lenses like a smaller optical zone, but Contex has customized, every lens is made by your parameter, so it is customized lenses. And there is a fortunately a distributor in India, Primex. Preeti Mistry is the optometrist who looks after. So use all this information and help the children, which are the future of our nation. And in summary, I would like to say that overnight orthokeratology can be best used for myopia management. It is alternative to LASIK, safe and reversible, very effective in children. If you combine with low dose atropine, gives fantastic results. Cosmetically appealing, it improves the confidence and personality of a child, and has no control, no restriction on his lifestyle. These are my references. Thank you very much. I'm open for any questions that you have.
Thank you, sir. That was a wonderful and detailed session. Let's open the platform to the participants. You can unmute yourself and ask any questions. The chat box is also open for if you want to type your questions as well.
So there is going to be some questions afterwards, okay? So better you ask if you have any doubts.
Yes. Please do ask. As it was informed previously for the quiz, the rules will be given to you later in some time for before the closing. So if you have any doubts on sir's presentation and anything else, you can ask. Sir, you have a question in the chat box. How is your experience with seed ortho-K lenses?
Zero. I don't practice seed contact lenses. I started orthokeratology 20 years back with Euclid. The founder of Euclid, Joanne Simonson, was kind enough to teach me, hold my hands. I stayed at her residence in US and learned all this. And I brought this technology in India. I trained about 12 ophthalmologists and made a tour across India, making it popular. That time, some of the ophthalmologists were not happy with LASIK, and they are the one who showed interest in learning about orthokeratology. And today I have a lot of sophisticated softwares. As I said, I practice in US as well. So we have a software called Wave where you can customize your lenses, and they are really wonderful. But Euclid works fantastic. Context OrthoK works fantastic, and I know seed lenses also works good.
Thank you, sir.
Can we do dual
There is
therapy
a
spectacle in
yeah.
OrthoK? If yes, means if your dual therapy term means optical stimulus and a pharmaceutical stimulus. That means dual therapy means spectacle and low dose atropine, or ortho-K or plus low dose atropine. If you're talking about the thing which I talked about as using some specialized lenses with a plano power, it will work, but you are just creating more and more myopic defocus. But if you want more stimulus, then use ortho-K plus atropine. So up to how much diopter we can custom design OrthoK lenses? As I said, up to -9 and up to -3 cylinder, the labs can do it. FDA approval is up to -5 only, so some lab will not do it, but there are labs like Context who can help you with more power. See, if you are talking about myopia control, then if the child is already above -5, then he's already gone in high risk. But for adults, yes, up to -9 you can work. As a new independent private practitioner, how to start OrthoK? So previously when I introduced OrthoK, I used to advise to use a trial set. Nowadays, you don't need a trial set. You just need good information, good knowledge, and a topographer. And the labs will help you is to if you send a topography image, K1, K2, refraction, and HVID, they will design a lenses for you. And as I said, they have a very good first fit success rate of 84 to 90%. And you start initially the low power lenses. Select the patients who are more compatible, more comfortable. They will follow your guidelines, and there are a lot of population which is coming back from US to India. All my American optometrists keep on asking me, give me the names of optometrists who are practicing OrthoK. I have formed a group of myopia control. A lot of practitioners are there. If you are interested, just send me a text and I will add you in the group. It's a lot of information available there. You can have a support from other experienced people. And I would suggest you start practicing orthokeratology. You just need to invest in topographer. If you don't have a topographer, you can use some corneal surgeon as your teammate. You can send your patient to the nearest LASIK center or corneal surgeon who has access to topography. Most of the corneal surgeons or ophthalmologists do have a pentacam. There are some companies who give on rent. The pentacam will come to your clinic, if you pay them 1200, 1500, whatever, 2000 rupees, and they can come to your center and do the measurements for you, give a printout. So you there has to be a will and wish to start the orthokeratology practice, and there are ways and means to do it. So how often should myopia progression be monitored? Methods are used for monitoring. As I mentioned, axial length has to be measured every 6 months. What is the take on your combine with atropine and ortho lenses? I already talked about it. How often do you start combination treatment? As I said, if the child is at high risk, I start both treatments. As any methods to calculate changes, axial length is the gold standard to measure the changes. How I have one patient given stainless lenses since year ago, is 8 year old, -8. So can we add mitro as a dual therapy? Yes, of course you can add a mitro. Now it is just as since 1 year, right? If there is no change, don't do it. If there is a change, then add atropine. It is not like you just tomorrow you start and then you just stop. If you really want to add dual therapy, just monitor it. There is a proof that the myopia is increasing, and then you add this, and then you check after 1 year what happened, and document everything. OrthoK is still a costly option in the Indian context. Is there any way to consider using GP lenses? You mentioned combining corneal GP lenses with defocus spectacles options. Similarly, can we think of using GP lenses with multifocal lenses, piggyback fashion? So even I thought so, but the papers, there are a lot of papers which talks about the RGP lenses are equivalent to spectacles, so it has no effect on myopia control as such. So if you really want for myopia control, then go for orthokeratology. Yes, it is expensive, but there are people, you give them an option, and if they say no, then it's okay. But you don't decide, hey, this patient can't afford, so I'll not give the option. Give the option to the patient, and let patient decide whether they want to spend that much money or not. Because if they don't spend money right now, at the age of 50, 55, 60, they are going to have a major problems, and then they have to spend a lot of money. Do you know how much a retinal surgery cost? And after spending so much money for retinal surgery, the prognosis is not that good. So prevention is better. Right now you have time till that child is less than 18-year-old. You can do something to control the myopia progression and give him a chance to live a normal life. If there is a progressive myopia with nystagmus, which myopia control method is good? Better you talk with your the ophthalmologist, and decide a strategy for myopia control in such patients. It is not a regular myopia. Nystagmus means that it has so many other issues by birth. So better you do a thorough checkup and then plan myopia control. Unfortunately, in India, the optometrists are not allowed to prescribe any medicine or drugs. So better to have some ophthalmologist working with you, or you working with ophthalmologist, and help your patients in myopia control.
So I think Mr. Souvik Chell, you can unmute yourself and ask sir if you have any questions. I'm sorry, Mr. Souvik, we're not able to hear you.
You can type.
I think he's rejoining again, sir. If there are no other questions, I think we can wrap up the session. Okay. Mr. Souvik has joined.
Yeah, am I audible now?
Yes, 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 you're audible now. Please ask.
Yeah, yeah. Thank you, Dr. Chandrasekhar, to clarifying that out. I actually want to just add something with that. Sometimes, I mean, we have limited option for orthoke, right? I mean, we can give the orthokeratology option maybe up to -6 diopter, and cylinder also if it is limited like 1 diopter or maximum maybe 1.5.
No, if you
So
have listened to my talk, I said you can correct up to -9 and -3.5 diopter cylinder.
So in case of cylinder, what will be the? I mean, I just want to come into that point only. I mean, you told around up to -9. So in case of cylinder, how much we can do
Minus
with our,
3.5.
up to -3.5 with -9?
Yes. Toric lenses.
Mhm.
Thank you, sir. Thank you for taking all the questions. So